Welcome to our listeners around the world. We have a special edition of the JAMA Editor's Summary, featuring all of the wonderful research published across the JAMA network and presented at this year's European Society for Cardiology Congress over the weekend. I'm Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network. In this special ESC podcast, we will be covering a range of important cardiology topics: atrial fibrillation, myocardial infarction, complete revascularization, aortic stenosis, treatments for heart failure, the cardiovascular effects of vaccination, and important trends in cardiology. For this discussion, I'm joined by some special guests: JAMA Executive Editor, Dr. Greg Curfman, JAMA Cardiology Editor-in-Chief, Dr. Bob Bonow, and JAMA Senior Editor, Dr. Phil Greenland. Welcome, everyone. Let's dive right in with research on atrial fibrillation. Greg, JAMA published 2 trials related to atrial fibrillation. Tell me about them.
Yes, thank you very much, Kirsten. The first clinical trial on atrial fibrillation, called the Amalfi trial, involved remote screening for asymptomatic atrial fibrillation. Patients in UK primary care practices were randomized to wear an ECG patch monitor for 2 weeks or to a control group that did not wear the patch monitor. The objective was to detect episodes of atrial fibrillation, and episodes were detected in 6.8% of the patched patients and 5.4% of the usual care patients. So wearing a patch for 2 weeks did increase the detection of asymptomatic atrial fibrillation modestly, but not to a very great extent and probably not clinically important. Over a follow-up period of 2.5 years, the rate of stroke was the same in the 2 groups. So the authors conclude that this kind of patch monitoring probably not a viable solution to reduce the rate of stroke in patients in primary care practices. We believed that this was an important negative study because this patch-based monitoring, remote monitoring for atrial fibrillation, is receiving some attention. And we don't want to over-interpret what it may be capable of.
That's excellent. And I can certainly say, as a primary care physician myself, this is an important question. So nice to see some more data on this topic. Tell us about the other trial.
The second trial involving atrial fibrillation was a catheter ablation clinical trial. And catheter ablation, of course, is now becoming a common therapy for atrial fibrillation. And an important clinical question is whether after successful catheter ablation, in which atrial fibrillation does not recur following catheter ablation, whether it's possible to safely discontinue oral anticoagulant therapy. And this study documented the absence of atrial fibrillation for 1 year in 800 patients who had undergone ablation therapy for atrial fibrillation. The patients were then randomized to either discontinue oral anticoagulation or to continue oral anticoagulation. The primary composite endpoint was stroke, systemic embolism, and major bleeding after 2 years of follow-up. And the primary outcome occurred in 2.2% of the patients who continued on oral anticoagulation, but in only 0.3% of those who discontinued oral anticoagulation. And the difference was determined primarily by more bleeding in the patients who continued oral anticoagulation. So the authors conclude that discontinuation of oral anticoagulation in patients in whom an absence of recurrent atrial fibrillation has been documented after catheter ablation may be safe. And the key here is to definitely document that atrial fibrillation is not recurring, because after catheter ablation, there's still the possibility that atrial fibrillation may recur, and there may still be a risk of thromboembolic disease. But the reason that we felt that this paper was important is that if clinicians can definitively document that catheter ablation has eliminated atrial fibrillation, that it is safe to discontinue oral anticoagulation.
Excellent. I believe we have a very nice editorial that accompanies this paper as well. Let's turn now to the topic of myocardial infarction. Phil, tell us about the Dan-Jur shock trial published in JAMA Cardiology, as well as the Sweetheart trial published in JAMA.
Sure, thank you. So let me start with the Danish-German shock randomized trial. What was published in JAMA Cardiology is a post hoc analysis of this trial, which is also known as the Dan-Jur shock trial. And this is a paper that involves an analysis of systolic blood pressure as a possible effect modifier of a microaxial flow pump-associated treatment of infarct-associated cardiogenic shock. So the background of this trial is that there was a major trial published in 2024 that randomized people with infarct-associated cardiogenic shock to receive microaxial flow pump treatment as a cardiovascular support in patients with shock versus usual care. And that study showed a reduction in all-cause mortality in the group that received the pump treatment. The problem is that the pump treatment is not only quite expensive, but is associated with a number of substantial complications, including bleeding in about 20%, limb ischemia in about 5%, and kidney complications in 40%. The investigators in this study have been interested in looking at subgroups that may receive more benefit so that the use of the pump treatment could be refined more clearly. So the original trial involved 355 patients. They were able to identify and measure the systolic blood pressure at randomization in almost all of them. And they eventually found that there was a cut point at approximately 82 millimeters of mercury systolic blood pressure where they were able to show a very substantial reduction in mortality of about 66% reduction compared to patients treated with usual care at that blood pressure level. And above that level, above 82 millimeters of mercury, they weren't able to show any benefit at all. There was an associated editorial for this paper by Nathaniel Smilowitz and Judith Hochman from the Grossman School of Medicine in New York. And they concluded that this post hoc analysis provides important new perspectives on patient selection for the invasive management of acute MI with cardiogenic shock. And they suggested, based on this analysis and a prior one that had looked at age as an effect modifier, that to optimize the benefit of this particular invasive and somewhat risky procedure, that clinicians should consider preferentially targeting the use of microaxial flow pump in individuals under age 80 with MI and cardiogenic shock who also have systolic blood pressure less than 82 millimeters of mercury on vasopressors. The second paper on myocardial infarction in the JAMA group is from Sweden. First author is Hoffman, and this reported results of a trial of Helicobacter pylori screening after myocardial infarction. And of course, the background here is that upper GI bleeding is fairly common after myocardial infarction, and their hypothesis was that by identifying through screening which patients have H. pylori infection during hospitalization for MI, that could potentially lead to appropriate treatment for H. pylori, which might reduce the risk of upper GI bleeding after discharge. The trial involved using a urea breath test to screen for H. pylori added to the standard care in patients hospitalized for myocardial infarction during the screening. And this was a somewhat interesting design. Won't go into the details of it, but they had a period where everybody got screened, followed by a period where no one got screened, And those two periods were compared for the appropriate outcome of upper GI bleeding. The study was huge. It involved more than 18,000 patients, randomized equally to the screening and the non-screening methods. They managed to conduct the screening successfully in about 70% of the patients who were randomized to screening, and there was a positive result of the screening in about 25%. Overall, the result was a little less than exciting. The outcome did not demonstrate a significant reduction in GI bleeding in the patients who had been screened for H. pylori. So the authors tried to understand what was the potential explanations for this null result, a number of different possibilities, but the long story short is that in this pragmatic randomized trial, they did not show a benefit of H. pylori screening. And that's an important observation, an important negative observation, and that's why we felt it was important to publish this in JAMA.
Okay. Bob and Greg, would be great to hear about the research published on the role of complete revascularization in myocardial infarction. Let's start with Bob.
Thanks, Kirsten. Yeah, we were very interested in the 3-year outcomes of the FIRE trial presented by Pascalia and co-authors. This is a study of 1,445 patients over the age of 75 with myocardial infarction and multivessel disease. It was a multi-center trial involving 34 centers in Spain, Italy, and Poland, where the primary outcome was a composite of death, myocardial infarction, stroke, or ischemia-driven revascularization. Patients were randomized to complete revascularization versus only revascularization of the culprit artery. Primary results have already been published at 1 year, showing a benefit of complete revascularization. And we are coming out with the 3-year outcomes of this trial, which pretty much confirm the earlier findings at 1 year. There was a reduction in the composite primary endpoint of 22.9% versus 29.8%, a hazard ratio of 0.72. That was significant. And a very key secondary endpoint of cardiovascular death and myocardial infarction, again, significant, 12.8% in favor of complete revascularization versus 18.2% for culprit-only. Looking at the landmark data we have, things did not change much after 1 year in terms of diverging outcomes. They ran parallel. And so most of the primary and key secondary events were driven by what we saw at 1 year, with the exception of hospitalization for heart failure. As you might expect, the patients who have complete revascularization may have less ischemia, less LV dysfunction, perhaps less heart failure. And what was found there was not only a significant reduction in heart failure hospitalizations at 1 year, but that continued to diverge over the course of the next 3 years. So we were quite interested in that particular aspect of the finding. And we're also looking forward to the 5-year data coming up at some point in the next 2 years. But we were pleased to publish the 3-year outcomes.
Wonderful. Greg?
Yes, thank you. And staying on the subject of complete coronary revascularization in patients with myocardial infarction, this clinical trial, referred to as the SLIM trial, was conducted by Pustians and collaborators, focused on non-ST segment elevation myocardial infarction. Patients had undergone coronary angiography, which demonstrated a so-called culprit lesion. It was believed to be the cause of the non-ST segment elevation myocardial infarction, but also demonstrated additional coronary artery stenoses. And the question was, following stenting of the culprit coronary lesion, should the operator go on and also stent the additional coronary lesions or leave them alone? And 478 patients were randomized to undergo complete revascularization or only culprit lesion revascularization. The outcome, which was a composite of all-cause death, non-fatal myocardial infarction, and any revascularization and stroke at 1 year, was a better outcome in the patients undergoing complete revascularization as compared with culprit-only revascularization. Now, it's important to understand that the difference in the primary outcome was driven primarily by repeat revascularization. So the authors conclude that in these patients, complete revascularization seems to carry more benefit than culprit lesion-only revascularization. Now, this concept of complete revascularization is now generally accepted for patients with ST segment elevation myocardial infarction. But again, the focus of this trial was on non-ST segment elevation myocardial infarction, and that is what is a bit more novel in this trial and was the primary reason that we thought that it was important to publish this paper in JAMA.
Excellent. Let's turn now to aortic stenosis. Bob, you have an individual participant data meta-analysis related to treatments for aortic stenosis for patients at low or intermediate risk. Tell us about that.
Kirsten, this paper, authored by Ludwig and co-authors from Europe, gives us a good look for the first time at individual participant data in a meta-analysis, because we've seen many meta-analyses of TAVR versus SAVR, that's transcatheter versus surgical aortic valve replacement, through the years in patients in this risk group, intermediate or low risk or combined, as in this case. This is the first one to give us individual participant data, which is kind of the gold standard for what one should do with a meta-analysis, where they actually have the individual patient data. Unfortunately, they could only do that in 4 trials that were investigator-initiated. Dedicate from Germany, UK TAVI from the UK, and the Notion 1 and 2 trials from Sweden. They attempted to get the individual data from the studies that had commercial sponsorship, but were unsuccessful. Too bad, because they had a total of 2,880 individuals in their individual patient meta-analysis, but if they could have included the data with commercial sponsorship in those trials, they could have had 3 times as many more patients, over 9,000 patients. They do make that point. So what they did was not only the individual patient meta-analysis, which is novel, but they also then did aggregate data where they grouped their data along with the other 4 commercial trials of the 2 different TAVR devices in the partner trials, Certabi and Evolut, and came up with an aggregate meta-analysis. So the novel finding, again, is the individual patient meta-analysis, where they were able to show actually a reduction in the risk of death and cardiovascular death. The primary analysis was driven by the endpoint of death and stroke, with TAVR versus surgical, which was not significant. But they did find in the individual patient meta-analysis a reduction in overall mortality as well as cardiovascular mortality. That was significant. This is limited by only 1-year data in the individual patient meta-analysis. The authors do plan to do further analyses once they have longer follow-up in the 4 trials that they investigated. But one of the take-home messages, kind of as an editorial, is that wouldn't it be good if everyone agreed that we should be sharing data to really find out what the real answer is? And it would be helpful if even commercial sponsors would agree to open up their database to allow these important meta-analyses.
Yes, that would certainly give us a lot more information, but it's good to see the first look at the IPD meta-analysis for those data that were available. Greg, tell us about the study that JAMA published related to treatments for heart failure. There's a lot of interest in the GLP-1 receptor agonist. Tell us about this study.
Yes, thank you. This was a study by Sebastian Schneeweiss and his co-workers, and the focus was on patients with heart failure with preserved ejection fraction, a very important cause of heart failure, now believed to cause more than half of all episodes of heart failure. And the investigators were interested in 2 drugs that have shown promising results in patients with heart failure with preserved ejection fraction in smaller studies. One, Semaglutide, which is a GLP-1 receptor agonist, and the second, Tirzepatide, which is also a GLP-1 receptor agonist, but also has activity for GIP. So it has a dual activity. And the investigators were interested in comparing these two drugs in patients with heart failure and preserved ejection fraction. And they did this by conducting an emulation study, not a randomized controlled trial, but emulation of randomized trials using observational data. So they conducted two studies that emulated randomized trials with semaglutide on the one hand and tirzepatide on the other, and found that both drugs were effective compared with a placebo proxy. In this case, they used sitagliptin as the placebo proxy. And both drugs were effective in reducing the risk of a composite of hospitalization for heart failure or all-cause mortality. They then proceeded to a second phase of their study in which they conducted a head-to-head comparison of these two drugs, again by trial simulation. And they found that there was no material difference, no clinically important difference between semaglutide and tirzepatide in patients with heart failure with preserved ejection fraction. Now, again, I emphasize that the investigators were using observational data, and they were emulating clinical trials, not actually conducting de novo randomized clinical trials. So that was the principal reason that we were interested in this work. Some investigators don't really have a lot of confidence in clinical trial emulation, while others are interested in pursuing it as a line of research, since, of course, not every clinical question can be the subject of a randomized clinical trial. So we felt that these were interesting results, not definitive, but interesting, and it will be especially interesting to see how they compare when subsequently actual randomized clinical trials are conducted of these two drugs.
Excellent. Let's turn to several papers published across the network that look at the cardiovascular effects of certain vaccinations. I'm going to start with the DAN RSV trial, which is a very large pragmatic trial out of Denmark that looked at the effect of bivalent RSV vaccination versus no vaccination on cardiorespiratory hospitalizations in older adults. It's a very large trial, over 100,000 participants, just conducted this past winter season in Denmark. And what the authors are reporting in this pre-specified analysis of the DAN RSV trial is that the incidence of all-cause cardiorespiratory hospitalizations was significantly lower in the group that received the bivalent RSV vaccination compared to those who did not receive the vaccine. There is a complication in this result, of course, that the differences in cardiovascular hospitalization did not reach statistical significance for a difference between the groups. But the data together raise the intriguing possibility that there may be potential downstream cardiorespiratory benefits of RSV immunization. This is certainly a very important topic for researchers as they continue to explore cardiovascular outcomes that might be associated as a downstream from these vaccines. And it's an important topic for clinicians and patients who are always seeking to understand the specific benefits of a particular vaccination. JAMA Cardiology also published a paper from this same group looking at the cardiovascular benefits of high versus standard dose influenza vaccination. Bob, maybe you can tell us about that.
Thanks, Kirsten. We were interested in this trial, given its design and its potential implications at the population level by Johansson and co-authors. It's a pre-specified analysis of the DAN-Flu 2 trial. And what we are publishing are the cardiovascular and cardiorespiratory clinical outcomes in this trial. The reason we're interested is because this is a very large trial. enrolling 332,432 individuals during 3 consecutive peak influenza seasons in Denmark. They enrolled patients online. Patients gave informed consent online. Very nicely done, pragmatic trial. And the primary results of the trial, which are published elsewhere, were negative. The primary outcome of the trial was hospitalization for influenza or pneumonia, and that was neutral given high dose or low dose of this inactivated influenza vaccine. And that gets in then to the weeds of how one interprets secondary analyses in trials that are neutral, specifically because this trial also used a hierarchical analytic design, which was pre-specified, that if the primary outcome was neutral, any secondary outcomes would not be analyzed statistically, but only reported descriptively. And that's what we have. So we have the data on cardiorespiratory hospitalizations, cardiovascular hospitalizations, and hospitalizations for heart failure. Again, without giving this any statistical inference, but it was found that the high-dose vaccine was associated with lower rates of cardiorespiratory, cardiovascular, and heart failure hospitalizations. And from a relative reduction in events, again, this is significant, it seems powerful. And for example, a 7% reduction in cardiovascular hospitalizations and a almost 19% reduction in heart failure hospitalizations. That's the relative risk reduction. However, when you look at the absolute risk reduction, you're dealing with really fractions of a difference, kind of clinically negligible, if you want to put it that way. The cardiovascular disease reduction was 1.3% versus 1.4%. So it's a difference of 0.1%. And the heart failure hospitalizations with a relative risk reduction of 19% was actually driven by a difference of 0.03%. So it's heart failure hospitalizations of 0.13% in the high dose versus 1.6% in the standard dose. So it depends on how you want to interpret that. From a clinical point of view, these are very small margins. But one could argue that if we're talking about influenza vaccine, vaccinating millions of people worldwide, these relatively small absolute differences actually could amount to a larger number of reductions in hospitalizations from a cardiovascular point of view. So depending upon how you interpret the relative versus absolute risk reduction, there could be important implications here. That was addressed by Rob Califf in an editorial for us. Dr. Califf, of course, is the former FDA director in the United States. Very interested in large-scale pragmatic trials, very interested in vaccinations as well. He got into the same discussion we just had about how to interpret relative versus absolute risk reduction. But more importantly, his editorial also gets into the need for us to do a better job in getting large databases and large clinical trials that can be done pragmatically, as has been done in Denmark, and perhaps using our electronic medical records to advantage. Why can't we do that in the United States? I think that's an important take-home message of this trial.
Excellent. And it's nice to have the editorialist comment on this study, not only the results, but also the need for these large pragmatic trials. And certainly this is a very active question, the comparison of the high dose versus standard dose influenza vaccine, and an important question at the population level, as you suggest, but also for individuals as they think through the choices clinicians and patients make each influenza season. There's also a research letter from the same group that looks specifically at the outcomes of myocarditis and pericarditis, reporting a lower incidence in the high-dose influenza vaccine arm. That's published in JAMA Network Open. Let's turn to another study about myocarditis and pericarditis, but on a different intervention. This was also published in JAMA Cardiology. Bob, maybe you can tell us about that.
Yeah, Kirsten, we were interested in this study from the group at the Broad Institute, MGH, the Brigham Hospital, as well as investigators in Belgium and Sweden, using the UK Biobank data to look at the incidence of clonal hematopoiesis of indeterminate potential, or CHIP, and the risk of new-onset myocarditis or pericarditis. As we're learning, CHIP has emerged as a novel and potent cardio risk factor among older individuals based on multiple mechanistic studies, large observational cohorts, and also population-based biobanks, including UK Biobank. This phenomenon increases with age. 10 to 20% of individuals over 75 have evidence of CHIP. This is a clone that has emerged in the bone marrow and begun to repopulate as well. It promotes inflammation, kind of provides a inflammasome as well as activating IL-1 axis-mediated inflammation. No proven therapies, no data that we need to treat this, evidence that it should be treated. But what these investigators did was to look at the incidence of and severity of CHIP and the incidence of myocarditis over the course of 13.7 years. Any CHIP variant, meaning 2% of the cell population, was present in 3.3% of the population. And over 10% of the variant allele frequency in the cellular population was present in 2.2% of these individuals. The mean age of this group was 52. And so it's a relatively young group showing a pretty high prevalence of CHIP, but as you might expect, the individuals with CHIP were older, had some other risk factors, including diabetes. But in the multivariate adjusted analysis, the hazard ratio of developing myocarditis was 1.71 in individuals with any CHIP, and in individuals with what we call large CHIP, meaning more than 10% of the cellular population, the risk of subsequent myocarditis, pericarditis was 2.0, kind of showing a dose-response effect here, that the more CHIP, the higher the risk of myocarditis. Relatively small numbers of individuals who develop myocarditis in the population, as you might expect. It's 0.1% of over 11,000 patients they studied. Only 382 developed myocarditis or pericarditis. But the presence of CHIP was associated with a much higher likelihood. And that 1.7 to 2.0 hazard ratio is actually greater than the risk of developing coronary disease or heart failure, which has been very actively investigated in the CHIP milieu for these inflammatory environment leading to ischemic events and heart failure. But actually, the likelihood of developing myocarditis or pericarditis is actually somewhat higher than that. This kind of extends the spectrum of CHIP-associated cardiovascular diseases, which up till now has been looking at chronic diseases. Now we're seeing a signal for perhaps a higher risk of acute diseases. It clearly is related to a higher risk of inflammation because the investigators also found that non-cardiovascular inflammatory diseases such as psoriasis and vasculitis were also related to CHIP. The issue here is it's retrospective, and we need to have prospective validation going forward. An excellent editorial from our Spanish colleagues, Domingo Pascual Figal and Jose Fuster, really gave us great insights into their interpretation of these data. Very active investigators in this field.
Okay, we're in the home stretch. Let's turn to the research that considers the trends in cardiovascular trials. So JAMA Network Open published an interesting systematic review that examined the participation of women in cardiovascular trials from 2017 to 2023 using data from clinicaltrials.gov. Across the more than 1,000 trials reviewed, the authors report lower numbers of women participants in clinical trials compared to men, and also lower number of women who participate in trials compared to the prevalence among women in the population with the specific conditions being studied. The underrepresentation here that the authors report is really striking, and the authors discuss the need for greater participation in clinical trials. And they issue a call to action for investigators to really prioritize representation of groups in proportion to the prevalence of the disease in the population being studied. I will say that although the representation is low, even in the most recent year that the authors reviewed, there is a little glimmer of hope in this study because there is an increasing trend towards more women in trials over this time period that they examine. Bob, you have another study that looks at trends.
Yes, we have a study involving a really important topic which has been understudied because of its difficulty regarding the epidemiology of cardiovascular disease in sub-Saharan Africa. This is reported by Agboyabara and co-authors representing the University of Paris, INSERM, and WHO, giving us longitudinal data in sub-Saharan Africa and Algeria, which are the countries represented in the WHO Africa region, where we have, again, very little data, but the need for more data given the emergence of non-communicable diseases in these countries. These are looking at national surveys from these countries, and they drilled down to 22 countries where they felt they had adequate data, Algeria and 22 sub-Saharan countries. And what they did was to look at Life's Simple 7, the American Heart Association's metric of cardiovascular health. As you know, that includes 7 metrics: smoking, ideal weight, physical activity, good diet, and healthy levels of cholesterol, glucose, and blood pressure. They investigated 73,000 adults in 22 countries, mean age of only 35, with a weighted prevalence of ideal cardiovascular health of 26%, roughly 1/4 of the population, intermediate cardiovascular health of 57.9%, and poor health in 15.9%. So 1 in 7 individuals in these countries felt to have really poor cardiovascular health metrics. And factors associated with the low metrics were older age, female sex, lower education, heavy alcohol consumption. In addition, there were issues regarding smoking, in particular in men, 19% smokers. Women had higher levels of obesity, 14% also associated with the poor health. And one of the issues here is lots of missing data in these surveys. It's a good start, but we need to have more solid data going forward, especially if the WHO wishes to achieve its 2030 global NCD targets. And the other finding was that there was no change in the cardiovascular health metrics over the last 2 decades. Again, possibly because of limited data and missing data, but again, at least an attempt to begin to put some light on this important subject in Africa. We were able to get an excellent editorial from Gerald Bloomfield, a global health expert at Duke University, who gave us the overview here as to why this important information is necessary at identifying actionable factors to improve cardiovascular health status, which would be crucial for guiding policy efforts in cardiovascular disease in this region.
Excellent. Some really very interesting studies across a range of important topics related to cardiovascular health. Thank you so much to all of my co-hosts on this podcast, Dr. Greg Curfman, Dr. Bob Bonow, and Dr. Phil Greenland. And thank you for tuning in to hear what was presented at the European Society for Cardiology this year. Again, I'm Dr. Kirsten Bibbins-Domingo, the editor-in-chief of JAMA and the JAMA Network. This episode was produced by Dr. Krista Roberts, Shelley Steffens, Matthew O'Connor, Daniel Morrow at the JAMA Network. A link to this JAMA content can be found in the episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.